I've been at this position for about 5 years. Prior to that, I was a military optometrist. This is how I envisioned myself. It probably wasn't that dramatic. I was usually just in a clinic situation. Today I want to talk about the eye and aging, and I'm going to start from the anterior part of the eye, actually to include the lids, and we'll move to the posterior portion of the eye. This will be geared more towards aging, and I hope to bring a perspective to you that is similar to myself as being a non-ophthalmologist, and that some of my experiences can relate to the way that some of the patients present to you in your clinics and healthcare situations. Now, although we're going to be talking about aging situations, a lot of the topics that I talk about today relate to many different age groups. As you can tell from this little girl, if you look at her spectacles, she shares a common problem that many of our aging patients have, and that is that she has had cataracts removed. Fortunately for this little girl, when the cataracts were removed, we were able to fit her with contact lenses, and so since she's been just a few months old, I've followed her with her lenses, and she does well to this date. Now, as a benchmark, we use visual acuity. And to just refamiliarize yourself with it, visual acuity is expressed as a fraction. The numerator is the distance at which the patient reads the chart. The denominator is the distance at which someone with normal vision reads the eye chart. So this is typically where the numerator is 20 feet, and typically the normal person reads the 20/20, and this is how we get it. Now, to put that in perspective, someone that has 2300 vision, to say that differently, is a person with normal vision 20/20 can stand away from an object 300 feet and see the same thing that the person that has 2300 has to get up 20 feet to see. You should always measure visual acuity as the first thing in an eye examination. Just some information about visual acuity. 20/40 is the standard that the DMV uses to require that patients wear eyeglasses to drive. Some of our patients can't read the biggest letter on the eye chart, which is usually 2400. So in your offices, just have them walk forward until they can identify a letter. In this particular case, this was 10400. In other words, the patient at 10 feet could identify the biggest letter on the chart. Even if they can't identify letters, we want them to be able to count fingers. CF at a certain distance. Just hold up, how many fingers am I holding up? They will tell you, and then when they get it correct, you record that distance. That's an acuity. If they can't count fingers, it's hand motion. Do you see my motion with my hand out in your field of vision? If they can't see that, can you see my pin light? If you can't see that, then there's no light perception. Our government has established 2200 when that is the best corrected vision as legal blindness. Now, when a patient comes to you, the chief complaint is the blurred vision related to a refractive error, or is the blurred vision related to pathology? Now, we use this simple little gadget right here, if you want to project this to those at home or at the other locations. Now, what this consists of is an occluder which blocks out, in this case, her right eye, and then we're able to flip this little lever right here, and it clears out the little pinholes so that the patient uses their best correction, what they think is their best correction, and they get a reading on the chart. And then we flip these little pinholes in. And if their visual acuity improves, we know that the vision loss is related to a refractive error, and that will help with your diagnosis. The reason this works is that no matter what the refractive error, central rays of light go unrefracted. You can mimic this same thing in your office. If you just occlude one eye, press a few pinholes in a 3x5 card and look through it, you will see 20/20 vision. So if we're not interested in refracting the patient, we just want to get right to the root of the pathology, this gives us an idea of what to do. Now, of course, blurred vision is the major complaint that patients come to us with, and I want to briefly touch on some of the refractive errors. This is what keeps, as Dr. Krause says, his daughter going to college. This is what keeps my daughter in college, and that is correction for refractive error. Myopia, by far the most common refractive error. Myopia occurs because the cornea is either too steep or the eye itself is too long. It's usually a combination of the two, however. The patient complains of blurred distance vision and relatively good near vision. As the patients age, myopia becomes less. And also, in some situations, a cataract will cause a patient to become myopic, so that mimics a myopic correction. And this is what the older people will say, I've got my second sight back. Their vision at a distance is blurry, but that goes unrecognized to them. It's simply now that they're able to see better up close, they now feel like their vision has come back to them. Now, the previous doctor was talking about the diabetic situation. This is used a lot in his profession with hyperbaric medicine. They have a large portion of this at the TDI. We also have one across the hallway from my office in University Hospital. But this is the waiting room of the hyperbaric medicine. And some of these patients will undergo a large change in myopia. The highest one I've seen has been up to about 7 diopters. That means a patient that has 20/20 vision could go to a point where they could not see your hand in front of you in about 5 feet. So be aware. In most cases, this does regress. Hyperopia occurs because the cornea is not steep enough, or the eye itself is too short, or in most cases a combination of the two. Now, the hyperopic young patient usually doesn't have any complaints at all. They can see both distance and near very well. The older patient will have both distance vision and near vision blurred. When you look at our prescriptions that we write for them, and I should note here that it's corrected with a plus lens, and that's designated on the prescriptions that we write. The first number of the three lines that we'll write has a plus or a minus. A plus lens indicates to you that the patient is hyperopic. Many patients do carry their optical prescriptions with them. The minus indicates a myopic patient. Astigmatism simply means that the eye's two principal meridians that are 90 degrees apart do not have the same curvature. Astigmatism usually does not change very much with age. If it starts to change, then we have to think more of changes in the crystalline lens or some type of a cataract starting, or even maybe a corneal problem. The typical analogy is that the basketball versus the football. The basketball has no astigmatism, all the meridians have an equal spherical component to it, and the football, this meridian is more curved than this, and patients tend to understand that analogy, but typically does not change with age. Now, this is the common complaint that you have with patients as they age. Somewhere around 40, the crystalline lens inside of the eye becomes less flexible, and patients say that I cannot see close distances anymore. They tend to move things out, and that's why their complaint is my arms are too short. And it's very graphical, and you can just go down the line here. The nearsighted patient who is getting less myopic may notice, well, I don't see as well as I used to without my eyeglasses. Now, methods to correct refractive errors. This is a contact lens. And for those of you who do not deal with contact lenses very much, you may be asked in some situations to remove one that had become displaced, or asked to be seen if there's still one in the eye. Again, this is a hard lens, but if you also look on the outside here, you'll see another contact lens. That's a soft contact lens. So the hard lens is fitting on top of the soft contact lens. This happens to be my eye. I have an aging condition of my eye, whether instead of becoming spherical, it's starting to become conical, and so it's called keratoconus. And the only way I can compensate for the visual acuity is to wear this hard contact lens. The soft lens is used to cushion the lens here because the cone causing the irritation. with this, you may even see this little opacification in the middle of my pupil. Another popular way to correct refractive errors has been refractive surgery. Your patients who've had refractive surgery a few years ago had what was called an RK procedure, where the surgeon actually made incisions into the cornea hoping to flatten certain meridians. The newest type of surgery done is called LASIK, where a little flap is created here and a laser sculptures the eye. You will not see any type of scarring from LASIK surgery. You'll see it only in these RK situations if you look with a pin light. The problem within some of these situations is that these individuals who had usually a myopic or astigmatic refractive error initially, now 10 years later, are reversing. And so that instead of being myopic, they're becoming fairly farsighted. This patient had gone from a -6 up to a +6, which is a 12 diopter change. And of course, as they've aged over 10 years, that's affecting their vision, both distance and near, significantly. The LASIK surgery, which is available now, does correct for myopia, hyperopia, and astigmatism. But your patient should be aware that it does not correct for presbyopia. So if a patient has normally seen pretty well without glasses and has the procedure for the LASIKs to compensate for this, they'll no longer be able to read where they could at one time. To compensate for this, the surgeons will sometimes induce myopia or leave one eye slightly undercorrected. Now, when you look at the eye, you tend to think, well, let's just go right and look at the eye and see what's wrong with it, see what the patient's complaint is. But as Dr. Cross mentioned, it's kind of nice to sit back and look at the patient. This is a veteran, and very typical, if you can back out on that just a little bit, I want to get you in the habit of looking at the patient as a whole. In this particular case, you can see these wrinkles in the forehead. The patient is trying to lift the eyelids up. There's a significant amount of dermatochalasis here. Here's a little lesion that maybe Dr. Krause might want us to take a little closer look at. We notice that there's slight swelling here, a little ectroping of the eyelid. And then maybe the pupillary reflex is not the same. And then also it looks like there's a little more light being reflected back off of the pupil. I'll show you a picture of this a little bit later on. Now in ophthalmology and optometry, we have very sophisticated layer. We can actually measure the retinal pigment epithelium and nerve fiber layer, but you don't have that advantage. But taking a good history and using a pin light, you can diagnose many ophthalmological conditions. The pupils can be tested. You can test the anterior chamber depth. You can check ocular motility. So the pin light, very significant. Now we'll start with the lids and go through. The lids serve a very important function. They sweep foreign bodies from the eye. Most importantly, they contain the glands that make up the tear film. This is a condition that you commonly see in your clinics. This is the common stye or hordeolum. This patient presents as a painful red eye. The immediate treatment for this, and the best treatment for this, is to apply hot compresses to the lid. And by this I mean to have someone run hot water on a washcloth as hot as they can stand it, hold it against the eyelid for at least 5 minutes, and then following that to massage down in the upper lid, and if it's on a lower lid, to massage up and get that to drain. Often they do not drain, and you'll get this granulomatous type lesion, which we now term a chalazion. It is not painful. It does go away with time, but sometimes they're big enough that they can actually affect the vision. So if a patient comes into you with one of these chalazions and says that it's affecting my vision, you would think that's kind of far out. That's not the case. They actually do swell enough that they press the cornea and cause a stigmatism correction. This looks like a stye or hordeolum. This is not. This is an acute infection, dacryocystitis. So this is a lacrimal system, the canicular system. The only treatment for this is systemic antibiotics. The problem here is that sometimes this tends to chronically damage the canicular workup and can affect that tear layer that's so important to the health of the eyes. This is very common with the aging patient. You get this, what we call blepharitis, or inflammation along the lid margins. These little collarettes are from the mucus that grows as the eyelid grows out. It grabs a piece of it and goes right out with it. The cause of this is just poor lid hygiene. And the typical solution for this in most situations is just to write a prescription for an antibiotic ointment and spread that, but that does very little good unless this area is clean. So the best method to clean these and get rid of this situation is to use baby shampoo. Baby shampoo doesn't sting the eye. You apply it to a warm washcloth, scrub along the eyelashes, and a lot of this will resolve on its own. The toxins from this type will interfere with the integrity of the cornea and cause a foreign body sensation that you may think is mimicking some other type of disease. Now here's another little lesion that looks like the another sty or hordeolum, but Dr. Krause very accurately described what this is. This is the typical pearly border, and so this is a basal cell carcinoma of the eyelid. Very common in the eye area, especially for the lightly skinned patients. Now, whenever you examine the eyes, you should always pull down the lid and look at the conjunctiva. This conjunctiva up here is white. It will sometimes have pigment on it. This part of the conjunctiva should never have pigment. If it does, refer the patient immediately. This is a malignant melanoma on what looks like a very unsuspecting type pigmentation. The only treatment for this is to remove the eye and also remove the orbital contents to save this person's life. Now this looks like a serious lid condition, moderate inflammation around the eyelids. This is iatrogenic. This lady came in for just a treatment of a conjunctivitis or a blepharitis and was given neomycin drops and became an immediate allergic reaction to that. We seldom use neomycin in ophthalmology because of that reason. Also, when you look at the patient, you want to look at the position of the eye in relationship of how much forward they are. This is, in particular case here, is thyroid disease, Graves' disease. These patients will complain of dryness here because the lids don't close very well. In its advanced stages, the extraocular muscles will be compressed, the optic nerve can be compressed, the patients can lose vision, and at least lose function of the eye muscles and have double vision. If you should see one of these patients that just has exophthalmos on one eye, you should be very suspicious for a mass. Now, I can't emphasize to you enough how important it is to study the tear film. The tears are made up of three layers: the oil, aqueous, and mucin, and they're produced by these various glands within the eyelids. Now, by far, the most common prescription that we write for eye drops is for artificial tears. They're also over the counter. This particular patient here is an extremely dry eye, which has a mucin deficiency, and in this case, there's actually tissue that is forming across the conjunctiva called symblepharon, and is on the stage to very serious eye problems. In some situations that don't advance this far, lubricating drops and ointments are prescribed. Also, in the little punctum here, you can artificially close these with little inserts. Now let's go to the conjunctiva, just to refresh your anatomy on that. The conjunctiva is a membrane that is on the inside of the lid, goes up and makes a loop, and then comes down and connects to the globe. This part of it is called the bulbar, where it's on the globe, and this the palpebral. This little area here is called the fornix. Now this presentation of conjunctivitis wouldn't be very hard to miss. This is an obvious bacterial conjunctivitis. And the hallmark of bacterial conjunctivitis is this purulent discharge. But very rarely does a patient present with bacterial conjunctivitis, although we treat many of them like they are. Most of them are viral conjunctivitises. And the thing that helps me differentiate different types of conjunctivitises is to pull down the lid again and again look at the palpebral conjunctiva. If you see these little lymphoid lesions without a vascular network, this kind of a glassy appearance, and a watery discharge, these are your typical viral conjunctivitises. They're very contagious, they'll usually limit themselves out, and often they're associated with a preauricular adenopathy. Around here we see a lot of allergic conjunctivitis. The hallmark there is itching. And even though the eyes may look fairly white, it's important to look under the upper eyelid. It's easy to do that. You simply grab a hold of the eyelids, pull forward and press your finger on a little cotton tip, and the lid will flip over and you'll see these giant papillae. Now papillae have these little vascular networks coming up, and that's sort of how you can differentiate them. Also, they're not as symmetrical. This is a situation of one that's flipped over, upper lid, and again, not quite as dramatic, but these are very common to see these papilla. They're very common with people who wear soft contact lenses, especially those that are not disposable, and we call this a giant papillary conjunctivitis and grade it by how high it goes up on the lid. Antihistamines and mast cell stabilizers are very effective in this, and they do now have ophthalmic drops that are BID dosing, so your contact lens patient can still continue to wear contact lenses. Now this looks like another conjunctivitis with the inflammation through this area, but look also over here. Conjunctivitis, the inflammation decreases as it approaches the limbus. The limbus is the area between the cornea and the conjunctiva and the sclera, this little zone right here. If the inflammation is increasing around the limbus, all the way around, refer that patient. This patient has iritis, has an inflammation going on inside of the eye, some other things that might give you a little bit of a clue. The pupil will be a little bit smaller than the fellow, and the patients typically will be photophobic, but not always. So don't try to treat this as a conjunctivitis and refer it to an ophthalmologist as soon as possible. There's also scleritis, where the sclera does become inflamed, often with rheumatoid arthritis, which is common in our aging patients. These are very common. This is one situation where topical corticosteroids are of value. They'll usually resolve pretty well. Now this, I've never seen a situation like this, but there was in the series that I had. This patient, the sclera has completely eroded, or the white of the eye has completely eroded, and this is the uvea that you're seeing. This eye would not be seen, and probably this patient would not have too much life left. Commonly seen in Texas are these little lesions, and this is caused by ultraviolet light. This is called a pterygium. The tissue grows onto the cornea and has this appearance. It can come from either side, usually starts on the nasal side. A lot of times these patients also work in dusty environments. The typical one is a person that works in a cement factory, that sort of thing, outside a lot, that does a lot of landscape type work. Now they don't like to remove these unless the patient complains about them for a cosmetic reason, or if they start to advance into the visual axis and start to affect vision. The reason that they don't is they will tend to regrow. And if you remove them too many times, the cornea will thin and it will induce an irregular astigmatism, and vision can be affected. Now let's move on to the cornea, the next layer back. If you ever see a white spot in the cornea, you should refer it. This is a corneal ulcer. This that you see in the lower layering section here is actually in the aqueous, or the inside of the eye. That's white blood cells, and you can tell the eye is moderately injected there. These are treated, they're cultured first, and then they're treated with fortified antibiotics around the clock until they clear. The problem with them, if they do successfully treat it, it'll still leave a scar, and this one is right in the visual axis, so this patient will need a corneal transplant. even though the cornea ulcer does heal. This is why you see corneal ulcers. This is actually a case that I took away from a patient about 6 months ago. You can just see how filthy it is, how, you know, it'd be so simple to clean that case. But if the ulcer, even with a break in the epithelium from a dry eye or just a little rub in the eye or something like that, and Pseudomonas attacks the cornea, you can lose the cornea within a matter of a day. In our older patients who have arthritis, this is a corneal ulcer, and this is actually thinned and has a chance of perforation. Something that you see commonly in your practices is herpes zoster, trigeminal here. And it was curious that Dr. Krause mentioned the Hutchins syndrome. We have a similar type thing here that we say if this little lesion shows on the tip of the nose, then we need to look into the eye because it's a nasal ciliary part there. But that's not necessarily true. You can still have these lesions up here and have involvement in the eye. The primary involvement in the eye is anterior uveitis. It does, what I want you to look at in this and the next picture, it does have this kind of dendritic appearance on the cornea. But this is the classic, this is herpes simplex of the cornea. This is a rose bingle stain, but you could get your same stain with fluorescein, but it has this dendritic appearance. This one very typical, this one atypical. This is also a herpes simplex. Now this is why we don't routinely use corticosteroids in the eyes as eye drops. If you put corticosteroids on this, it's like throwing fuel on a fire. It'll really take off and cause severe damage. A lot of times these do heal very well with antivirals, but they will still sometimes scar and they often reoccur. Another situation, this one's a little more dramatic than most, is these are corneal dystrophies. This dystrophy is enough to significantly affect vision. The dystrophies are classified by the layer of the eye that they are in and how their shape. So with a simple pin light, you could pick this up very easily. Now I put this one in here because this one's fairly common. This happens to individuals over 50. This is Fuchs dystrophy. And the patient will start to complain to you that they have a foreign body sensation, especially they don't see too well in the morning. And when you put your pin light up, you get this, the cornea just doesn't look very clear, and it's called an orange peel effect, like the outside of an orange. The initial stage of this, if you'll just have the patient get a hairdryer and hold it a few feet from their, or 2 feet from their eyes and blow it towards their eyes, will dry out this corneal edema. The problem is that there's a endothelium mechanism breakdown, and so the eye does not hydrate. It usually goes on, however, to get these microcysts and then these bullae. They become very painful, and you have to have these patients have a corneal transplant. Now this is what a corneal transplant looks like. This is 2 days after surgery. This is a remarkable procedure. These grafts do very well, up to 95% of them graft very well. So what happens, this is a full thickness cornea here that is trefined out. This is a donor cornea that is placed on there. Then there are sutures to hold it into place, and then a running suture is made into here. Most people, especially patients who have the condition that I have, which is keratoconus, this is the end stage. They automatically assume that this is going to be a cure-all. It's really not. What will happen throughout about a year's time is that the patient will come in on a regular basis, and we will take a topographical measurement of the eye. We may find out this meridian is steeper than this meridian, so a suture may be cut here. They'll go home for a month, then come back, and we monitor this until we try to get it as smooth as we can. But many times, you still do not get a very good vision through a corneal transplant, and you often still need to wear a contact lens or some type of optical device. But it has saved the sights of thousands of people, a remarkable operation. Now let's move to the pupils. Looking closely at this pupil patient again, we see in this case The lower lid on this side is down, the pupil smaller. And if we would have this lady run up and down the stairs a few times, we'd find out this part of the face doesn't sweat. This would be red over here and it'd be white over here. This patient has a Horner syndrome, which is ptosis, meiosis, and hydrosis. And this is a sympathetic problem. An acquired sympathetic lesion has to be investigated for tumor. The congenital Horners will have a heterochromia. The affected side will be lighter because the sympathetic innervation is involved in melanocytes. Now, just to look at this patient initially, you would think this is a very poor outcome. This patient had a cataract removed a few years ago when they used to remove the cataract through an incision up here. This is the pupil that they left. This is an iridectomy to avoid glaucoma. Actually, this patient sees 20/20 vision. The lid's just pulled up. It'll come down right here. He gets that pinhole effect, and that's not a problem. Some of these can be surgically induced, as I mentioned, but also from trauma and these sort of things. Often not a problem. Now, for the healthcare professionals, I always want to put this slide up. This is a picture taken of the office right next to me, which is the cardiac catheterization laboratory. And the chief of the services told me that they receive more radiation than any professionals in the health care hospital. You can see here they have leaded aprons. They'll also wear one that comes here, and then they wear one around the thyroid gland. Many of them, though, fail to wear leaded glasses. They do provide leaded glasses to fit over their glasses, or for those in that environment, they do make prescription leaded glasses. Because they will advance the cataract formation. Now, this is what a cataract looks like. This we would call an immature cataract. It's called immature because the whole lens is not involved. But this patient has been dilated, so the pupil is larger than normal. So you could see that if this pupil was normal, that the cataract would be getting in the line of sight. The surgical criteria for removing a cataract that we get reimbursed for with our insurances is usually 20/60 to 20/70 range, or if the patient has significant glare, which we can measure. We sometimes intentionally dilate the pupil for a person who has a cataract this size so that they can see around the cataract, particularly in children who are born with cataracts. Now, this is a mature cataract. This you would be hard to misdiagnose, but you can see the entire cortex there is opaque. And so this is a mature cataract. Now, cataract surgery has changed significantly. When you talk about a patient, you talk to a patient and tell them that they have cataracts, especially the older patients get very alarmed because they remember the days when their parents or elders had cataract surgery. They were put in the hospital for 2 or 3 weeks. Their head was sandbagged, and then when we were able to come home, they came home with very thick spectacles and did not do very well. It's completely changed now. A cataract surgeon who does a lot of these can do a surgery in about 20 to 30 minutes. They make an incision of about 3 millimeters in the cornea in the temporal side. They take an intraocular lens like this. It's folded in half. They go into the cataract, they phacoemulsify it, it is sucked out through a port, and then this little intraocular lens is placed right into the sac. Its power can be determined by determining the curve of the cornea and also how long the eye is. So if a patient wants to be left just a little bit nearsighted so they have distance and near vision, the surgeon can gauge the power of this with the lens that they put in. Now, previously, we used to tell patients that, well, we'll correct the vision for no refractive error, but you'll still need to need glasses to read or bifocals, and that's because you're replacing the crystalline lens. But this newer technology, in fact, actually has the bifocal in the intraocular lens. So this will be the technology of things to come. Also, you should note here, YAG tolerant. Many of the patients, for some reason, think that you remove cataracts with lasers. You don't. What does happen, though, in about 10 to 20% of the time, the capsule that the lens is placed into will opacify. And so that these patients come back and you look at them, usually with a slit lamp, you'll see the opacification of the capsule. And so the surgeon will take a YAG laser right in the office and just blast a little circular a hole through the capsule, and the vision comes back instantly. Also remember, if a patient says to you that my vision after I had the cataract surgery was pretty good, but now it's getting worse, it needs to be referred immediately. Those patients may have just made the capsulotomy, but also it may be to the situation where they have a detached retina, or they may have some central edema. Now this is that patient that I showed you the full face view, and here you see that the iris here is torn. This patient was in a motor vehicle accident. He took such a blow that he detached the retina, tore this iris away, but what you can still see is this little haptic. The interocular lens stayed in place. That's the lens there. And as you can imagine, what this patient complained about to me was significant glare. He was very photophobic. So we do have some help for these type of situations. Now this is the same patient, so what I did in this case was to get him a soft contact lens, have it painted so it matched fairly closely to this eye. Then I corrected his refractive error. When they correct the retinal detachment, it usually changes the refractive error. And then paint the back of that black and then leave a clear pupil. So we've taken care of his problem again. This is an interesting slide. Occasionally you will get a patient that has Marfan syndrome. This patient has crystalline lens. This is the iris. This is the crystalline lens. And these are what hold the lens in place, little zonules. And Marfans, those become very flaccid, and the lens actually subluxates. These patients are difficult patients because depending on where they look, they're either phakic or they're aphakic. We try to get them where they're phakic and correct this part of the vision with glasses, but because of the curve of the lens there, you get high degrees of astigmatism. Now, our medical students have a hard time using the ophthalmoscope. As you practice, it gets better and better, but I always tell them, don't turn the instrument all the way on. You just barely need it on. Don't use a large aperture, the smallest aperture that you can, and by all means get as close to the patient as you can. The closer you can get to the patient to the point that they actually blink because you're so close means that you're in the right position. But to this audience, I want to point out what happens right here. When you get a number in there, if you ever pay attention to that, it'll be either green or red or black. If it's red, it indicates that the patient is myopic, and you're essentially neutralizing the patient's refractive error. So if you see the patient does not have glasses on, and you visualize the fundus and they have a red number there, question them about that. In your older patients, if you see it's either green or in the new instrument or the older instrument's black, and you're up to about +2 or 3 diopters, they should be wearing glasses there. So again, that gives you a situation that you should question them about their vision. The next question is, do you dilate or not? What you're concerned about with dilation is that you'll get an acute glaucoma attack. Most glaucomas are the open angle variety. Very small percentage are the angle closure glaucoma, and that's what you're concerned about doing. But if you do close an angle off, it's actually a good provocative test, and you've done the patient a favor. What will happen is that the patient will come back to you about 3 to 4 or 5 hours after you've dilated them with intense pain, and so if you give them instructions ahead of time to report to your office, you can counteract this. What we use is Madriacil, which is 1% tropicamide. Then we use 2.5% neosynephrine, and that gets a very good dilation. We only put the proparacaine in because these 2 drops tend to sting a little bit. Now, if you're concerned about the effect, if you just want to get a minimal effect in dilation, even a millimeter or 2, just 1 drop of this and wait about 20 or 30 minutes, will significantly dilate the pupil to give you a much better view of the retina. Now remember too that this is a it paralyzes the accommodation, and so cycloplegic, what I'm trying to say. Okay, it's a cycloplegic. So if you have a patient that is hyperopic, is not wearing glasses, they won't be able to see to drive home. So be a little cautious there, and then they'll need to wear their sunglasses. But I think it's very important for eyes to be dilated. By law, when I first came out into practice, I was not allowed to dilate, so I've looked at hundreds of eyes through non-dilated eyes, so I know exactly what you see. But every patient that comes to me nowadays gets dilated. This is what an acute glaucoma attack will present as. The normal intraocular pressure is about 15 millimeters of mercury. These may shoot up to 50 to 70 millimeters of mercury. The patient has an intense pain. And what happens, why the attack occurs, is the pupil has been dilated, and then when it goes back down there, it seals off, and so the fluid has nowhere to go through the angle here. The person who is taking care of the acute angle will stimulate the pupil with miotics and beta blockers and lower the pressure. Once the pressure is down, they'll put laser iridectomies in, and the fluid will flow again. It's better that it happen in your office than you know, in somewhere that someone's out on vacation after just gone to the movies. Now this is what you see with your ophthalmoscope. This is what you hope to see. This is the optic nerve. It has a good color. The vessels, the veins have a ratio of about 2 to 3 to the artery here. You can see the blood flow through there nicely. This area is the macula. There's no spots. It's pretty uniform. Although you can't see it too well in there, there'll be a little foveal reflex right here. This white is normal. This is the nerve fiber layer, so you hope that that's in good shape. So that would be the normal appearing fundus. This is what happens in hypertension. You can see that the vessels change colors. There's what we call right angle nicking. A lot of times there'll be a hemorrhaging here, a beating of this. As this advances, you'll get cotton wool spots, which are ischemia, and also in some situations damage to the optic nerve. This patient would present to you as a sudden, painless loss of complete vision. This patient, and if you look at this, you don't see very much actually. This patient has a central artery occlusion. And so by the time they get to you, there's not much to do, and the patient usually will not recover vision. On the other hand, this is a central vein occlusion, and it looks terrible. You see all the blood in here. This is not considered a medical emergency. This will absorb on its own. Usually you don't see it this dramatic, where it's this. You usually see it in the branches of the veins. The problem is here that these patients do need to be followed, though, because they may develop neovascular glaucoma as the condition heals. Now I want to talk a little bit about neurology and neuro-ophthalmology. Again, we get out our pen light, and a simple test to determine if there is optic nerve damage is what we call a swinging flashlight. In this particular case, light is being shown into the left eye. The pupil constricts. The other eye, the pupil constricts. Now when we move the flashlight over here, the pupil should constrict. If it does not, and it in fact dilates, that's what we call a Marcus gun or a positive afferent pupillary defect, and we know that we have ocular nerve involvement. Also, you can use your pen light to check for binocularity. In this particular case, the reflexes are seen off of each cornea. The patient is fixating on the pen light. When the eyes are looked without the hand up there, you'll see two reflexes, and they should be centered equally in the pupils. If they're not, you have a strabismus or non-binocular situation. Now when you put your hand up there, you block off this eye, and if this eye was out here, it would move over. There would be some kind of motion. If you had an esotropy, it would be in and it would move out to move to where the fixation. You can also have it vertical deviations as well. In the older patients, we carry this one more step. You're taught with what's called a cover-uncover, but we also alternately cover the test. Many of these older patients will have total fusion and use both eyes together, except when they start to read. And so when you do the alternate cover test, you'll find that a huge switch of each eye as it comes in to maintain fixation. So these are phoria positions where the eyes are binocular, but this is causing problems and just a general asthenopia, and the patients will complain to you. Also, a note about color vision. When you have ocular optic nerve disease, you lose color vision. And I wanted to point out here that the patient is doing the color vision test monocularly. That's the way it should be done. Most of you in your offices do it binocularly because you're just trying to get a job classification or something like that. But it should be practiced so that each eye is tested individually so that you can monitor optic nerve. This is papillitis, or optic neuritis. This one happens to be right at the optic nerve head. Most of these happen behind the optic nerve head and behind the eye. And this is where you call what is called the retrobulbar optic neuritis. And we typically say the doctor sees nothing, but the patient sees nothing. And optic neuritis is common with multiple sclerosis. This, on the other hand, if you look in there, is papilledema. Of course, remember that you're looking in just one plane, so you're not seeing this in stereopsis. But if you follow the course of the vessel, you'll see that there is some elevation here, and so you can tell that this optic nerve is swollen. This is because of intracranial pressure and is non-inflammatory. A lot of the patients that come in with papilledema to the eye clinics are very benign situations, common pseudotumor cerebri, some of them, of course, very serious. Now this fundus looks fairly normal initially. You have a fairly good color, the vessels all look fine, but look how pale the optic nerve is. This patient has optic atrophy and would not have a very good vision, would have the positive afferent defect. And these can be caused by diabetes, they can be caused by papilledema, optic neuritis, glaucoma, many situations. But the take-home point here is to look at the color of the optic nerve. This is a tumor of the retina. Fortunately, you do not see too many tumors in the retina, and if you don't dilate, you won't see any, because more than likely they're out in the periphery. Interocular melanomas occur in 0.05% of our population. This is what a retinal detachment looks like. This commonly is not uncommon in elderly patients. This is where the retina has detached. The view is a little hazy just because the media of the vitreous. And so the patient will come to you complaining that they're seeing flashes and floaters. Flashes and floaters means dilate the patient, look at them immediately. In this particular case, if this one is advanced very far, if it goes down much farther, it's going to take the macula off with this, and this will need a procedure where they have to put an encircling band around the globe and try to get the retina to reattach. So if you can pick up a retinal detachment before it's just a little tear or something like this, they will go in and just laser around the tear and save the patient probably his vision. Now, what also happens with the elderly, somewhere around age 60 to 65, they will all complain of seeing flashes and floaters, and that's because the vitreous, or the chamber in front of the retina, has also detached. And so those patients need to be looked at carefully and followed. Occasionally when the vitreous does detach, or as it becomes more liquid, it will detach the retina with it, but usually not, but they still need to be followed very carefully. So particularly right around, almost invariably around age 62 or 63, they'll complain of that. You don't have to dilate the patient too much to see this condition, but it does help because you need to go to almost to the mid-equatorial area. And if you see this patient will complain of night vision blindness and also some motility loss because of a small field of vision. And this is what retinitis pigmentosa looks like. Retinitis pigmentosa has a genetic origin, and these patients need to have genetic counseling and be referred to a low vision clinic. Now this is a little tear-off sheet that we give every patient that we think might have macular degeneration. it's simply just a grid. These squares are all the same size. The lines are the same intensity. And the way these tests are done is you occlude one eye just by holding this over your hand, and you look at the little spot here, and you look for any disruption or metamorphia of these lines. And if that happens, we tell the patient, well, come in immediately. We have them put this on a bathroom mirror or on the refrigerator or something like they can see that. Now sometimes patients will present to you just with reading a line of newspaper. They'll see part of the letters of a word missing, or it'll look like it will hump up. That means that they are having macular involvement and need to be seen. This is a shot of the macula right here. This is a macula hole. And this was caused by someone looking at an eclipse. And this is why we tell viewers of eclipses to look at it from the back with a shadow type device. The sun actually burns a hole in the retina. And even though some of these can be repaired now, best visual acuity in this eye will be somewhere around 20/60. Now this is commonly seen when you look into a macula area. We call these little drusen, and they are disruptions in the retinal pigment epithelium layer, but these are precursors to macular degeneration. And macular degeneration is the leading cause of blindness in the elderly. So when they see this, or you tell them this, well, we want you to be a little extra cautious. We want you to take home the Amsler grid because we think that you may have or you may get macular degeneration. They are very scared. So look very closely at the macula. This is where a dilation does help, but it's fairly easy to see the macula without the dilation. Now this is another picture of macular degeneration. This is what you see. This is with the macula magnified. Now they have reason to be frightened because there's not much we can do about this. If you go on any distance beyond out here, visual acuity is like 2100 to 2400, so it's essentially blind. So these people do lose their central vision. They do lose their independence. They no longer drive, so it's a very frightening thing. Now recently, they have started to do a operation on the macular degeneration, but I should first say that there's actually two types. There's one called dry and one called wet. If there's fluid or edema in here, that's the worst kind, although sometimes the ophthalmologist can use a laser to stop the leaking. A lot of times that one will deteriorate very quickly. But a new operation that's being done is called a retinal translocation. And what they will do is actually purposely detach the retina and move it over a few degrees to where underneath the retina is a healthy, there's no neovascularization. And I had a fellow in my office about 6 months ago who was blind, 2400 in both eyes, went to Johns Hopkins and had this operation done, although there are two surgeons in San Antonio that are doing now, had his retina relocated, and the visual acuity is 20/40, so it's a whole new life to him. The reason he came to me was he also had double vision because the brain cannot orientate that, and so we had to use special eyeglasses to get him to use the eyes together. Now, as I mentioned earlier, glaucoma is a concern with our older patients. And when I first started in this business, if we had a pressure of above 20, then we would refer the patient for a glaucoma evaluation. And we didn't pay too much attention to the optic nerve. So now everybody should pay more attention to the optic nerve, and they should be able to evaluate what we call the cup to disc ratio. This is the cup of the optic nerve as compared to the disc. This one happens to be about 0.2 or 0.3. So that we have found out that you can have an optic nerve that looks like this, have a pressure of 14, and have advanced glaucoma. So if you see an optic nerve that has a large cup to disc ratio, even though you measure interocular pressure as normal, the patient should be referred for an evaluation. Now, a big area that's been talked about today is diabetes. This is what's called non-proliferative diabetic retinopathy. You used to know it as background retinopathy. It's now divided into non-proliferative and proliferative, and then they're divided into different groups. But the typical presentation in the diabetic are these dot and blot hemorrhages. What I want you to take home from here is that even though this is considered the mild stage of a non-proliferative diabetic retinopathy, if you look in the macula, there are some hard exudates. You can still have clinically significant macular edema even with non-proliferative diabetic retinopathy. So we need to measure visual acuity and follow those patients very closely. Now, when you get neovascularization, then you go to the proliferative diabetic retinopathy. You can have NVD, which means neovascularization of the disc, or NVE, neovascularization elsewhere. But what happens is that these vessels bleed, you get vitreous hemorrhage, and you also get tractional retinal detachment. So this needs to be treated, and this is why we ask that diabetics have an eye examination once a year. This is a diabetic that has been treated. Here is the optic nerve, the macula, and if you look at all these little white spots here, these are laser burns. This is panretinal photocoagulation. The ophthalmologist will apply about 200 to 300 of these at a session, missing the blood vessel, treating here, and then have them come back until they get the whole 360 degrees. And this has been the greatest thing in ophthalmology to my understanding, because it has kept vision in these patients who would normally go blind very quickly. You would think these people would have a large central scotoma, but they do very well. And that's all I have for this afternoon. If there are any questions, I'm glad to answer them.
Curious, being a contact wearer myself, as far as your thoughts, any particular concerns with contacts in the elderly, or just in general even contact wear? I use the AccuView, which I am fairly liberal with, and I think I do a good job of using drops and all, but I leave them in for a full 2 weeks and take them out.
Okay.
I know there's varying opinions on that.
That's right. The question is, what about contact lens wearers in elderly patients? What concerns do we have? The doctor wears AccuView contact lenses, which is a Johnson & Johnson brand, for 2 weeks at a time. We actually, personally, I tend to discourage extended wear use. The eye gets its oxygen from the atmosphere during the day. So when you have a membrane, which is the contact lens there, you get fairly good oxygen to the cornea. At night, you get the oxygen from the inside of the eyelid when it's closed, and so there's a chance for corneal edema. If corneal edema is significant enough, you'll get a break in the epithelium, and that's when you have a chance to get a corneal ulcer. You might suppose that an older person, it's a good point that you bring up. Many of these patients are aphakic. They didn't have the intraocular lenses when they had to have a cataract removed. So many of them do put in these contact lenses, and even though I instruct them to move them every night, they just their hand action, they're not don't have the dexterity to move it, so they'll often leave them in sometimes 3 or 4 months. Many of them do well, but also we'll get some back that have corneal ulcers and can have complications. Okay. Thank you.